they're not comfortable talking about mental disorders. So that's what we're trying to do. We're trying to really get at those cultural differences that often interfere with the unknown. So, well, thank you very much.
Thank you so much. Great talk. Sean is in the jacket over here. He's going to give you the ride. Thank you to your team. Again, let's give Dr. Sackner a big hand. Thank you. Gary? Our next speaker is Gary Tsai, talking about Safe Med LA County's Prescription Drug Abuse Coalition. Thank you, Gary.
Thank you. Good afternoon. When I saw the schedule that I was following Dr. Satcher, I was very, very disappointed in the scheduling. But very happy to be here today. Gary Tsai, I'm Medical Director and Science Officer of the Substance Abuse Prevention and Control, which is a division of the Los Angeles County Department of Public Health as well as the health agency. I'm a psychiatrist and also certified in addiction medicine, and we'll be talking a little bit about our county-wide prescription drug abuse coalition, known as Safe Med LA. And before I got into some of the details, I wanted to just take a quick poll of those in the room who have actually heard of Safe Med LA. If you could just raise your hand. Great, okay. I'd like to get an idea of how good of a job we're doing outreaching. So it's good to see that some people in the room have heard of Safe Med LA. It sounds like you had some information earlier in the day about the opioid epidemic, and so I hope I don't overlap too much. And if I do, feel free to let me know and throw some tomatoes at me. So I'll be talking a little bit about the data, then going into an overview of Safe Med LA, specifically what we like to call the 9-6-10 approach, and then we'll be wrapping things up. So framing the issue, this is probably one of my favorite slides on the opioid epidemic, and it shows that the U.S. population comprises about 5% of the global population, and yet we consume about 80% of opioids. I think that figure in and of itself underlines why we're in the predicament that we're in terms of how readily our communities reach for opioid pain medications. Hydrocodone, actually reading Vicodin most commonly. The United States uses about 99% of the hydrocodone. And so I think these numbers help to kind of set the stage for why we have this problem in our country. There's been a lot said about what's going on nationally. Prescription opioids have been driving drug overdose deaths, which have expanded beyond the number of deaths from motor vehicle accidents as well as firearms. And so this is certainly, as Dr. Sastra has mentioned, not just emerging but present issue that has reached epidemic proportions. Looking more locally here in Los Angeles County, prescription drug abuse contribute to a fairly significant portion of the overall drug overdose deaths, which have also surpassed motor vehicle accidents and firearms relatively recently, actually in 2014. Emergency room visits as well as hospitalizations related to opioids as well as heroin have been going up. Both of them actually have been going up, approximately 30% for hospitalizations and over 200% for opioids related visits. Interestingly, these increases in utilization in the ED as well as in the hospitals has not significantly resulted in opioid-related deaths in LA, as far as we can tell right now. Over the past 10 years or so, our average has been approximately 400 opioid-related deaths per year in LA County. This is something that we're looking into, and also one of the reasons why we're so interested in the work of Safe Med LA. We know that if there are increases in emergency room visits as well as hospitalizations, that there very well may be an increase in overall overdose deaths shortly thereafter. And typically what happens on one side of the country oftentimes trickles over to the other. And so in some way, our coalition is intervening early, even though this epidemic has been ongoing in other parts of the country for some time now. This slide emphasizes some of the cultural differences. This was mentioned in a question earlier. And what I want to point out is for opioid-related ED visits, you can see that white and black populations tend to comprise the majority of opioid-related ED visits. For heroin-related ED visits, a majority white men. And so there are cultural differences. Although we need to dig a little bit deeper into available data, we think that these cultural differences likely are contributing to the fact that the opioid epidemic hasn't quite hit Los Angeles County quite as hard as it's hit Vermont, New Hampshire, some of these other areas of the country. We do know that there are cultural differences in terms of how readily certain cultures reach for pain medications when they have pain versus, the individuals in the United States who are using 8% of the global population of opioids. In terms of prescriptions filled in Los Angeles County, hydrocodone comprises about 2/3 of the opioids that are prescribed. You can also see that sedatives comprise almost equal amounts in terms of opioids. I think that it's necessary that we're focusing on the opioid epidemic now. I also think that in the near future, we'll need to be focusing on sedatives, and particularly as we all know, the combination of these can be fatal. In terms of prescribing, 25% of the prescribers in Los Angeles County prescribe about 90% of opioids. This is one of the reasons why we're focusing on safe prescribing guidelines, one of the reasons why the CDC guidelines that came out recently are relevant and helpful. If we can touch and impact the providers who are prescribing, even the top 25%, we can really impact the majority of prescriptions that are written in terms of opioids. So moving on into Safe Med LA, this is our broad cross-sector public-private coalition that's taking a coordinated and multi-pronged approach to address prescription drug abuse. The core rationale for the coalition is that we know that the prescription drug abuse issue is multifactorial and is quite complex. And generally with problems that are this complex, a single solution will not be sufficient. And so we really wanted to take what we call a blanket approach, where we're addressing all of the different components that are contributing to prescription drug abuse simultaneously, as opposed to addressing one side of the issue and allowing another side of the issue to balloon up. So an example is if we restrict access to opioids with safe prescribing guidelines and we don't offer access to things such as medication-assisted treatment or addiction treatment, it's possible, and some studies have shown that we can actually funnel people from dependency on prescription drugs to heroin. Some studies have shown that this link isn't as strong, but there are some studies that are also showing that it's a risk. And I think that just anecdotally and speaking with our providers, that we have seen cases where that's been evident. Another reason why we wanted to establish this coalition is because there were a number of different efforts that were happening around the county, but they didn't always work together, and sometimes they weren't even aware that there were others in the county working on issues that were related. So an example is we had a prescription drug abuse medical task force focused on safe prescribing guidelines. We had an overdose prevention task force focused on naloxone access. We also had pain management work groups, as well as safe drug disposal boxes at various sheriff stations around the county. And we really wanted to take this coalition opportunity for us to work together and identify ways that we can synergize our interventions. We have a number of health organizations, hospitals, provider groups, associations, health plans, as well as county departments involved. This list isn't exhaustive, but just wanted to demonstrate that this is absolutely a team effort and that there are a number of contributing parties. So when we started, we developed a strategic plan in order to form the backbone of this coalition. It's a 5-year strategic plan, and the overall goal is to decrease prescription drug abuse-related deaths by 20% over the 5-year course of the plan. We take what I referenced previously, a 9-6-10 approach, so 9 action teams focused on 6 priority areas and 10 key objectives. The 9 action teams are depicted here, just to run through some of them so that you have an idea of how we're approaching this issue. We have 2 groups focused specifically on safe prescribing guidelines. One group is comprised primarily of pharmacists, another group comprised primarily of medical practitioners and physicians. When we started the coalition, we realized that pharmacists oftentimes were a underrepresented and sometimes overlooked group when addressing opioids. We do know that pharmacists oftentimes are the last health professional to see an individual before they have access to the opioids, and so there's an important educational opportunity there. There's also an opportunity because there was recent legislation in California that allowed pharmacists to furnish naloxone without a physician's prescription. And so we knew that their role would be expanding. So we really wanted to emphasize their unique role in our health system, particularly with relation to opioid issues. We also have a medication-assisted treatment action team, which I actually co-lead. And the idea is to increase access to medications such as buprenorphine and Vivitrol, so that people have alternatives in the event that they no longer are able to access opioids that they've been misusing or perhaps abusing. We also have an action team focused on naloxone access, which is the opioid overdose prevention medication. Action team focused on safe drug disposal. There's a lot of prescriptions out in the community. As Dr. Satcher had mentioned, people can, or at least in the past, it was fairly easy for someone to get a month's worth of medications even though they had a sprained ankle, and really only required a couple days worth of medications. And so there have been a lot of stories about people in the community who wanted to find a place to dispose of their medications and didn't have ready access. As I mentioned, we have 21 sheriff drug drop-off boxes around the county, but not everyone wants to go to a sheriff station in order to drop off prescription drugs. And so we're interested in diversifying the options for people to get rid of their prescription drugs. We have a law enforcement action team to focus on both the safe drug drop-off expansion as well as potential opportunities to work together around information sharing and also allowing patrol officers to carry naloxone, which is something that there are some other counties in California doing this, notably San Diego, Ventura, Santa Barbara, and can be a potentially life-saving opportunity. We have a community education action team focused on community outreach, and we're focusing a lot on our substance use prevention providers who are very familiar with the issues affecting their immediate community. And we'll also be releasing a media contract shortly in order to help educate the public about the prescription drug abuse issue. CURES is the prescription drug monitoring program here in California, and there was a recent update as well as recent requirement as of July 1st that all physicians register for CURES. The key here is that physicians aren't necessarily required to actually utilize CURES. And so one of the things that this action team is focusing on is how to increase the actual utilization of CURES that we identify when people are obtaining the prescription drugs from multiple sources. And then lastly, we have a data collection action team in order to help facilitate access to and the utilization of various data that's available. that action team is actually very critical in order to ensure that our teams are working in a measurable way so that we can evaluate our progress. I mentioned 6 priority areas, and I don't think I'm going to go into all of the details, but we do focus on education and training. I mentioned the community education action team, treatment and overdose prevention. I mentioned medication-assisted treatment as well as naloxone, tracking, monitoring, data exchange, safe drug disposal, enforcement, and then lastly, community trends and policy. The 10 objectives are detailed more on our website, and so I'll if you're interested, feel free to navigate our website to take a look at what some of these objectives are. But in the interest of time, I'm going to try to leave some more time for questions at the end. So in terms of the progress that we've made, we've implemented safe prescribing guidelines at all of the 76 emergency departments, as well as 80 urgent cares throughout the county. Urgent cares have been, actually both the emergency departments as well as urgent cares were somewhat difficult to engage given that the particular medical director leadership, there's a lot of turnover, and also with urgent cares in particular, there isn't a widely used association or trade group that they associate with. And so we had to individually outreach to a lot of the urgent cares, and now we're working through the health plans in order to access them. We know that there's about 260 urgent cares throughout the county, and so the next phase of our work will be engaging the remainder of the 180 or so urgent cares that are out there. Important to note, when we implemented the safe prescribing guidelines in emergency departments, we started getting calls from urgent cares saying that they were seeing more people showing up at their urgent care clinics, possibly because people were having more difficult time accessing their opioids in emergency departments. And so there is, I think, a trickle-down effect in terms of where people can access their opioids. And also, in terms of safe prescribing, I also wanted to mention dentists. In LA, we know that about 12% of opioids that are prescribed by dentists, and so this is also another group under our Phase 2 project that we want to engage in our safe prescribing guidelines. In terms of access to naloxone and medication-assisted treatment, we've been working with pharmacies. I mentioned earlier that pharmacists can actually furnish naloxone without a physician prescription, and also are establishing learning collaboratives in order to increase the capabilities of federally qualified health centers as well as primary care clinics in order to prescribe medications such as buprenorphine. We're also convening a what we call a MAT, or a medication-assisted treatment learning collaborative, for our substance use providers in order to expand their abilities to prescribe MAT. In terms of community engagement, I referenced the media campaign previously, and then lastly, in terms of drug disposal, Walgreens recently started offering safe drug receptacles at several of their pharmacies around the county. We're interested in seeing the expansion of this, and are talking to some of our pharmacy partners in order to see how we can do this. Also recently, the Board of Supervisors had moved forward a motion in order to schedule drug take-back events funded through the pharmaceutical company over the next year or so. And so I think there's going to be a lot more work, a lot more progress made on the safe drug disposal aspect of this issue. Some key takeaways in terms of our coalition. In order for us to make a meaningful impact, it's really going to result or need to result in some kind of culture change in terms of how we as health providers shape the public's perception of what I call tolerable or acceptable pain. The notion that pain is bad and that we need to medicate away pain is something that is a message that I think health providers have been sending for some time now, and it's something that I think is gradually changing. And so to the extent that we can change culture around how our societies view pain and how they address pain, whether it's through non-opioid options such as NSAIDs or Tylenol and physical therapy, and also how people access addiction treatment, I think it's going to go a long ways in terms of our success in addressing the opioid epidemic. And then lastly, addressing prescription drug abuse multifactorially and ensuring that interventions are synergized has been extremely important. Through our coalition meetings, we've identified numerous instances in which our action teams are working together. For example, our law enforcement action team is actively working with our naloxone action team in order to explore ways that our law enforcement agencies can start carrying naloxone and offering it to individuals who are released from custody. Our pharmacy practice action team has also been working around the issue of naloxone, and so that's been one of the great benefits that we've realized in terms of working together. So with that, I think we have some time for questions.
Thank you, Dr. Tsai. This morning, Dr. Compton talked about just approved, FDA-approved 6-month injectable buprenorphine. Want to comment on that? I think that's going to revolutionize how we do it. Do you think that's going to be available in LA County?
Yeah, we actually just had a recent meeting about this. I think I agree. I think it's going to change the landscape of how we address opioid addiction. Some things that that I think may limit its immediate expansion. Right now, it's approved for individuals on 8 milligrams or less of buprenorphine, and so I think depending on the patient population that you're serving, that may limit or in some way impact its utilization. I know that a lot of the clients that we serve in the public sector tend to be on higher doses of buprenorphine when they are on buprenorphine. And I think it'll also just...
So you can't just start it right away. They have to already be on the oral.
Yeah, if someone's actually taking 16 milligrams of buprenorphine, for example, it's not generally recommended that they would use the implantable 6-month Probufen. And so some of it is dose dependent, but I think it's, in terms of the mechanism of how this medication is released over 6 months and how that can be used in other areas of addiction as well as in mental health treatment, I think is very promising.
I was impressed by the fact you shared that 25% of physicians prescribe 90% of the opioids. So you talked about an educational approach, a drug disposal approach, and a culture change approach. Is anybody talking about a regulatory approach or looking at the relationship maybe between pharma and that fact? Is that what you're practicing?
Yeah. That's a great question. I was presenting to a criminal justice group recently, and they made the same comment. I think that there are opportunities, as I mentioned, to share information between perhaps cures and law enforcement groups in order to identify prescribers who are prescribing outside the norm and in ways that are unsafe. My understanding is that that's going to require some some legislative changes in terms of cures specifically. But I think information sharing, not just with cures, but also between emergency departments. So in Washington State, they have something called the Emergency Department Information Exchange, or EDI. It essentially is a web-based program that allows information sharing across emergency departments, where you don't necessarily need to have the same EHR, electronic health records, so that you can access the same information. And so I think that the more that we can ensure either interoperability between electronic health records or at least access via non-electronic health record means to information, so that prescribers can be making informed decisions, and so that law enforcement can be identifying prescribers who are offering medications inappropriately, I think that will be a very, very useful tool.
I had a question regarding CChau and prescription drug coalition. The issue of gas, many institutions have expressed that this is an issue in ControlCounty. From your point of view,
that's a great question. You know, I showed the statistics earlier about how sedatives, primarily benzodiazepines such as Xanax, comprise about 40% of prescriptions that are written in LA. Opioids comprise about 43%. So you're right. Sedatives are a big and emerging issue. In terms of how SAPC, or the Substance Use Prevention and Control, is addressing this, with the, I didn't mention the DirectorCare waiver that we're working on right now, but as a part of the Affordable Care Act and the 1115 Medicaid waiver, there's an opportunity for us to really transform substance use treatment that's funded by Medicaid or Medi-Cal in California. And so as a part of that effort, we're really using that as an opportunity to expand our youth system of care for substance use as well as prevention, so that we can better identify youth who are using and misusing not just prescription drugs such as Xanax, but also illicit drugs. And you know, I think additionally I'd mentioned safe drug disposal being an important aspect. I mean, the data that Dr. Tsai showed, you know, about 2/3 of people get their prescription drugs from friends and family, oftentimes because there's extras left over in the medicine cabinet. So to the extent that we can make it easier for people to get rid of their unused and unwanted prescription drugs, I think that'll also limit access, community access for youth.
China, then Norma.
Thank you. I wanted to really emphasize the work of the coalition is very helpful. I wanted to ask in terms of now distribution. I hear about the sheriff's departments and individuals. I haven't heard much talk about the drug treatment facilities or families of people in drug treatment facilities who don't have option. And I'm wondering, are there efforts to also provide them as part of the addiction? You know what I'm talking about?
Yeah, naloxone. Yeah, absolutely. Actually, we had a meeting last week in order to start setting up a naloxone program at our county-run residential facility up in Antelope Valley Rehabilitation Center. One of the, and actually we have a number of naloxone distributors in LA, Homeless Healthcare LA, as well as LA Community Health Project, who have been dispensing and offering naloxone not just to individuals who use substances, but also to their friends and family. In terms of scaling access, I think one of the really important things will be how economical the intranasal formulation of naloxone is. I mean, it's one thing to offer naloxone in the injectable formulation, which it's not impossible to use, but it is more difficult. And the intranasal formulation really is, I think, going to make things much easier for individuals such as friends or family or law enforcement or first responders who aren't necessarily used to using needles on a regular basis. And so we are speaking with the makers of intranasal naloxone in order to see what we can do in terms of offering that medication in mass in a way that's accessible to a majority of people throughout the county.
In terms of your action, you mentioned a couple of instances where there was a cross-fertilization between the groups, and I only heard you mention one for the treatment providers. I'm wondering if there are other teams that they're participating on other than that. And we're finding, especially academically and in many other areas, that across disciplinary work brings up issues and something else and problems that we never thought about that in terms of the team conversation.
Yeah, good question. You're referring specifically to substance use providers, correct?
Providers, how are they being? They're frontliners.
Yeah. Well, sorry. And when you say providers, you're not referring to primary care or mental health? Okay. Yeah, okay. I just want to make sure. So for our substance use providers, we've been doing a lot of work around the drug Medi-Cal waiver that I mentioned previously and around MAT. In terms of things like, and also around naloxone. We've been working through our prevention providers around the Community Education Action Team. In terms of things like safe drug disposal, safe prescribing guidelines, law enforcement, we haven't been focused as much on that for our substance use providers specifically. I agree, I think there might be opportunities to explore that in the future. It's going to take some time as we roll out these different initiatives in order for us to focus our energies. Because right now, one of the reasons why I like to talk about Safe Med LA is try to get more involvement from community organizations as well as provider groups, because there are bandwidth issues in terms of what we're capable of, and the more people we have involved in the coalition, the more that we'll be able to do. So,
thank you so much.
thanks.
Okay, everybody come back at 3 according to that clock for the final sessions.